Assalamu alaikum. Good morning, everybody, and thank you for this nice introduction. And I'd like to thank the organizing committee for a kind invitation here to be with our colleague in nuclear medicine. We'll start our talk about the surgical pathology. Well, actually, I think it's very difficult for a pathologist to give a pathology lecture for non-pathologists. It's difficult for you and difficult for me. So please bear with me. I try to make it as simple as possible. I'm going to cover in this presentation about 4 objectives. First, I'm going to talk about classification of the thyroid tumors. I'm going to talk about the pathogenesis of full differentiated thyroid carcinoma and what's the clinical implication of understanding this pathogenesis. I'm going to talk about the diagnostic criteria for well-differentiated thyroid carcinoma. As a pathologist, how are we going to make this diagnosis? And finally, I'm going to talk about reporting of thyroid carcinoma, what items you need to include in our pathology report. Well, when we talk about classification of any tumors, we try to make a common language between different specialties, between surgeons, endocrinologists, pathologists, so that they understand what tumor we are talking about. Also to make international language between different geographic regions when patients transfer from one country to another, so they know what's talking about. Well, actually, I'm going to talk about the classification of WHO classification. There are different classifications, but I think the WHO is international language we can speak about. Unfortunately, the last classification was in 2004, and we are now in 2014, so now 10 years from. But this is the latest classification. And I think we are due now to get a new classification, and according to my personal communication, the experts are waiting the invitation from the WHO so they can sit for the new classification. In history, in the past, the classification used to be on morphology of tumor and clinical behavior of the tumor. But now, it's more, recently, they incorporated the molecular study and the genetic alteration, because now this genetic alteration is affect the prognosis, the biologic behavior of the tumor, even the morphology, as we're going to see in our topic. So we're going to start about the WHO classification. First of all, I'm going to talk the most common category we are dealing in our daily practice. First, the papillary carcinoma, which is the vast majority of tumor, considers 80%. Then follicular carcinoma. Then we have the poorly differentiated carcinoma, or what used to be called the insular carcinoma, and undifferentiated carcinoma, which is the anaplastic carcinoma. Then we have rare tumors also like squamous cell, primary squamous cell carcinoma, mucoepidermoid carcinoma, sclerosing mucoepidermoid carcinoma with eosinophilia. Then again, rare variant, mucinous carcinoma, medullary carcinoma, which arise from parafollicular cells, mixed medullary and follicular carcinoma, and we have very rare tumors of spindle cell that we have thymus-like differentiation. This is the malignancy. Then we have the benign counterparts of thyroid tumor, which is commonly the follicular adenomas and the hyalinized trabecular tumor. A third category, which is not specific to thyroid, which can occur in different parts of the body, like lymphomas, plasmacytomas, and mesenchymal tumor like sarcomas. Now, I'll take you back to the first slide. Papillary carcinoma, follicular, poorly differentiated, and undifferentiated. There is something missing in this list. What's missing? Hürthle cell tumor. So where's Hürthle cell tumor in the classification of thyroid tumors? Well, actually, before I receive the talk about what's happened to the Hürthle cell, I want to give you an idea what's Hürthle cell. I received a lot of calls from surgeons, from endocrinologists when they get the FNAC report, there is Hürthle cell. And they get worried about the Hürthle cell. Hürthle cell is a tumor characterized predominantly by cells with dense eosinophilic cytoplasm, hyperchromatic nuclei, and prominent eosinophilic nuclei. So this term is a descriptive for the tumor, descriptive for the morphology of tumor. It doesn't predict the biologic behavior of the tumor, as Hürthle cell can be seen in hyperplastic nodule, neoplastic nodule, benign, and malignant. So Hürthle cell, nothing has to do with the biologic behavior of the tumor. This is an example of cytology aspirate by Diffie-Quick stain, show the dense of Hürthle cell tumor, and you can see the dense eosinophilic cytoplasm. This is an histological examination. You can see the markedly eosinophilic pink cytoplasm, what we call eosinophilic or oncocytic, and this is because high content of mitochondria, and the enlarged nuclei with a prominent eosinophilic nuclei. So what's happened to this, what we used to call Hürthle cell tumor? Well, the study showed that if this tumor carried the nuclear morphology of papillary thyroid carcinoma, it has the same biologic behavior of papillary carcinoma, even they have the same genetic alteration. So they reclassified under papillary thyroid carcinoma oncocytic variant. And this is, I'm show some examples. This is an oncocytic lesion with dense eosinophilic cytoplasm. And if you look high power, we can see characteristic nuclear morphology of papillary carcinoma, the enlarged overlapped nuclei with the chromatin clearing. So these tumors are reclassified into papillary carcinoma. If this tumor doesn't carry any nuclear morphology of papillary carcinoma, then they are a follicular neoplasm. If they have a feature of invasion, like capsular invasion or vascular invasion, then it's a follicular carcinoma because they have the same genetic alteration, the same biologic behavior. So reclassified under oncocytic variant of follicular carcinoma. If they don't have any feature of invasive, then it's classified into follicular adenoma oncocytic variant. I'll show some example. Again, you see the same morphology, dense eosinophilic cytoplasm, but this feature, there is no nuclear feature of papillary carcinoma. And there is no invasion, no capsular invasion. So this is a typical oncocytic variant of papillary carcinoma. Another example, you can see dense eosinophilic cytoplasm and with a capsule. But this lesion is different. It's invading outside the capsule, going into the adjacent adipose tissue. So this is oncocytic variant of follicular carcinoma. So now in the latest classification, there is nothing called Hürthle cell tumor. Okay, there's either papillary carcinoma, either follicular carcinoma, or follicular adenoma oncocytic variants. Now, this is the first part. I'm going to talk now about the pathogenesis of follicular carcinoma neoplasm. And I'm going to concentrate more about the well-differentiated as the objective of this talk. This is a famous article published in Nature Reviews Cancer by Toronto group by Professor Asa. And this is a good article to review about the pathogenesis of follicular cancer. Nowadays, we know there is certain risk factor associated with thyroid carcinogenesis. An example of this, radiation exposure. And we know, as we know, after the several atomic bombs and the Chernobyl event, there is increase in the incidence of thyroid carcinomas, particularly papillary. Also, the external beam radiation. In the past, they used to be given for a benign condition, head and neck, for example, in acne. Now, not anymore, but they found this associated with thyroid carcinoma. Also, in areas with reduced iodine intake and lymphocytic infiltrate, and particularly cases with Hashimoto thyroiditis. So all these risk factors are associated with carcinogenesis. So what happened if these factors occurred? That's diagrammatic representation. If we have a risk, one of these or combination of these risk factors, this will cause genomic instability, such as loss of heterozygosity or rarely microsatellite instability. This genomic instability will cause early genetic alteration in RET and BRAF mutation. And this alteration will cause further genomic instability and will cause late genetic alteration. So we start for progression of the tumor from well-differentiated to poorly differentiated tumors, such as poorly insular carcinoma or anaplastic carcinoma. Now, this is a multi-step carcinogenesis. We know now in a lot of cancer, they have multi-step carcinogens. Start from benign neoplasm, then into malignant neoplasm. Like what we see in colon cancer, what we call adenoma carcinoma sequence. It's a sequence or accumulation of a genetic alteration that accumulate to form the cancer. So we start with this. If we get a benign follicular cells and we get mutation or genetic alteration in the RET or BRAF, which cause papillary thyroid carcinoma. If we get a further genetic alteration, including cyclin D1 or B27, which is the regulators of the cell cycle, then we get papillary carcinoma with high prediction with lymph node metastasis. On the other arm, we have these follicular cells. They get probably a RAS mutation, then we get a follicular adenoma, then we get PPAR rearrangement, it will turn into follicular carcinoma. If both well-differentiated carcinomas, they have a genetic alteration in beta-catenin or P53, this is a switch the tumor or the malignancy into a more aggressive tumor, poorly differentiated carcinoma. So I'm talking about the most important, as I said, the well-differentiated carcinoma. 70% of well-differentiated carcinoma, there is a genetic alteration involving mitogenic activated protein kinase pathway, or what we call MAPK pathways. As we're going to see in this representation, this is a physiologic reaction. This is a physiologic representation. This is the receptor. There's no pointer, sorry. This is the receptor, tyrosine kinase receptor. It has extracellular domain and intracellular domain. When it's attached by a ligand, the glial-derived neurotrophic factors, it causes autophosphorylation. It causes autophosphorylation. And go in this scheme to activate the RAS and BRAF and the BRAF, and then go downstream till it reaches the nuclei, which is activate synthesis of a transcription factor involved in the cell proliferation or cell differentiation or cell survival. So any genetic alteration in this pathway, will cause more proliferation of cells, more differentiation, and cell survival. So this is a carcinogenesis of this tumor. Somebody will say, now, oh, I get bored with all this genetic alteration. What's the value for me as a treating clinician? What am I going to do with this? It has a great value in our clinical practice. First of all, diagnosis. Now we know, now we do a lot of PCRs, especially for undetermined lesion on cytology aspirate. We can do this marker, the RET and PRAF and KRAS, and we can get a definite diagnosis for definite management. Also, some of these markers are available in our labs as immunohistochemical stain. We can do them in histological slides, so we can get a definite diagnosis or help us in the diagnosis of borderline lesion. Also, this tumor can predict the morphology of the tumor, like KRAS associated with follicular architecture, either follicular carcinoma or follicular variant of papillary carcinoma. Papillary carcinoma with papillary architecture, PRAF and RET PTC are more associated. And we know tall cell variant, which is an aggressive variant of papillary thyroid carcinoma, is more associated with a BRAF mutation. So this is regarding diagnosis, how it's useful. Also the prognosis of the tumor. We know now, a lot of studies show that BRAF correlate with a distant metastasis and more advanced clinical stage. So if you have a patient with BRAF positive staining or BRAF genetic alteration, so you have to closely follow up this patient and even give some aggressive treatment. Also, we found BRAF mutations in undifferentiated carcinoma with papillary component found in 70 to 78%. So BRAF mutations are involved in the progression of the tumor from well-differentiated to poorly differentiated. Also, cyclin D1 overexpression and PT27 downregulation can predict lymph node metastasis. So we can do in our tumor in the histological slides, and we can classify a tumor. Actually, when I started to work in Farwania Hospital, I get this marker as immunohistochemical stain. It's available, and we started to do them. But actually, I found the surgeons and the treating physician are not interested in this expression, although it's to predict the behavior of the tumor. So I stopped doing them, because we need to be aware of what's the impact of this marker. Finally, it's the treatment. Now, if you go in thyroid meetings, there's a lot of trials, a lot of papers coming about tyrosine kinase inhibitor. So now we see it's a lot of cases of well-differentiated carcinoma with refractory for iodine treatment. So this is a trial for them to give the tyrosine kinase inhibitor, which block all this cascade. Now, having said that about the pathogenesis, now the patient already excised the tumor. We get the definite diagnosis. Now, as a pathologist, how can I make diagnosis? What's the diagnostic criteria to make the diagnosis of well-differentiated carcinoma? I start with papillary thyroid carcinoma. It's epithelial tumor showing follicular cell differentiation characterized by distinctive nuclear morphology. That means diagnosis of papillary carcinoma by nuclear morphology. It has nothing to do with the architecture. Although the name looks papillary, that can be, it has a papillary architecture. But now we recognize only that tumor with this nuclear morphology, they have the same biologic behavior. So what's the nuclear morphology I need to make this diagnosis? Enlarged overlap nuclei, irregular nuclear membrane, chromatin clearing, intranuclear grooves, and nuclear pseudo-inclusions. This is more classic picture of classic papillary carcinoma. You can see the papillae with fibrovascular cords. This is high power view to see the nuclear morphology. You can see here the enlarged, hope I can. The enlarged overlapped nuclei, chromatin clearing, irregular nuclear membrane. Some nuclei are triangular shaped, some of them oval, some square. So this is due to irregular nuclear membrane. This is another spectrum of papillary morphology, papillary carcinoma. You can see the enlarged overlapped nuclei with the chromatin clearing. Now, so this is very useful because if you know papillary carcinoma diagnosed by nuclear morphology, so this is easy to diagnose and fine needle aspiration. But in contrast to follicular carcinoma, as we're going to see. Follicular carcinoma is malignant epithelial tumor of thyroid with evidence follicular differentiation and lack the nuclear morphology papillary carcinoma. It's account around 10 to 15% of all thyroid malignancy. It have higher incidence in iodine deficiency areas. There are different histological features. Follicular can be microfollicles, can be trabecular or colloid-filled follicles. However, the most important things to diagnose it, there is a feature of invasiveness. The first feature of invasion is capsular invasion, which is a tumor penetration through a tumor capsule associated with the previous fine needle aspiration. This is a classic picture. You can see this is a thyroid, a capsule. This is another edge of the capsule, a tumor, bulging outside, infiltrating outside, with all mushroom-like projection. So this is characteristic of capsule invasion of follicular carcinoma. Another form of invasion, you see a tumor surrounded by a capsule, and then another nest of the tumor outside the capsule. So this is again a capsular invasion of follicular carcinoma. The second feature we require is the vascular invasion, which is the definition, according to the WHO definition, a presence of intravascular tumor covered by endothelium associated with a thrombus. This is an example of a vascular invasion. This is a blood vessel, extracapsular. You can see the wall. Here the thrombus. And you can see this is a tumor infiltrating directly into the blood vessel. You can see here, this is the thrombus form. And this case is diagnosed as angio-invasive tumor. So, saying that, because we need the vascular invasion, capsular invasion, as we said, and as we previously from Dr. Muhammad's presentation, follicular carcinoma cannot be diagnosed based on cytology. You need the histological examination to make the definite diagnosis of follicular carcinoma. Now, I'll talk about the last object about reporting of thyroid carcinoma. Now in 2014 is the standardized reporting, or what using as what we call a synoptic report, is the recommended way of reporting, because we know now we know that this has improved the quality of pathology report up to 50%. So what item we need to include in this report and what's significant? First of all, we have to comment the procedure done by the surgeon, which is either lobectomy, hemithyroidectomy, or total thyroidectomy. Also, we have to determine the tumor focality, if it's unifocal or multifocal, because in the past it used to be believed that this is, if the tumor with multifoci, they are intrathyroidal metastasis, or from the same tumor. But the genetic studies show that all these tumors have different genetic alteration. So are there really different foci of different tumors? Now, the third thing we have to document is the tumor size, which has significant impact on the prognosis of the tumor. As in papillary thyroid carcinoma, tumor less than 1 centimeter, which is called microscopic papillary microcarcinoma, has an excellent prognosis. Whereas if it's more than 4 centimeter, it has worse prognosis. Same thing for follicular carcinoma, it's more than 3.5 centimeter, it has a worse prognosis. So documentation of the size of the tumor is very important. Now, the tumor site usually determined by the dominant tumor in cases of multifocal. However, if there is a multifocal tumor, also we have to document the second site of the second main tumor. Histological type, I've said, is extremely important for prognosis. Papillary thyroid carcinoma follicular are well differentiated, usually have good better prognosis than a poorly differentiated and the undifferentiated carcinoma. Now I will talk about the histological variant of carcinoma. What we want the attention when the clinician read the pathology report, what type of variant you should click? This patient maybe has a different behavior than other tumor. First of all, columnar cell variant, columnar cell, and solid cell. This type of tumor, the evidence shows that these tumors have aggressive behavior than the usual classic and the usual papillary carcinoma. And also the cribriform morular variant. We know now this tumor or this variant of papillary carcinoma associated with familial adenomatous polyposis syndrome or Gardner syndrome. So it's very important for the clinician when you see this variant in the report to send the patient for colonoscopy, because most likely this patient will not die from the papillary carcinoma, but he will die from the colon cancer that missed. So it's very important to know about some of these variants. I'll give you some example of a thyroid tumor. You can see this is a papillary carcinoma with hemorrhagic macrophages. It's adjacent to a cartilage. So this is very aggressive tumor invading the trachea. And if you see the high power, you can see this is the tall cell. The length of the cell is 3 times the width of the cell. So this is a tall cell variant of papillary carcinoma. Again, a columnar cell variant of papillary carcinoma. You can see some of the nuclei are here in this variant, hyperchromatic. The follicular arranged like endometrial gland. Again, this is a cribriform variant. You can see the follicles are rigid here. And you see this is the squamous morules in between and sometimes spindle cells. Now, I will talk about lymphovascular invasion. If you read the literature about lymphovascular invasion, there is a different definition. There is a tumor, someone said tumor cells within a vascular space, tumor cells underlying endothelium of the vascular channels. There are tumor cells in through the wall, invading through the wall of and the endothelium, and there is a thrombus adherent to the intravascular tumor. However, if you go to all this literature, you see the study showed the importance of vascular invasion in predicting the behavior of thyroid carcinoma is variable. For example, one of these studies by Nishida showed there is vascular invasion found in 47 in papillary carcinoma. However, only 8% they have distant metastasis. So this indicates there is no significant of this vascular invasion. The only reason there is no a great definition of vascular invasion. So I think, but recently there is a study shown recently published in Modern Pathology. The author used a rigid criteria to identify the vascular invasion. We know thyroid gland is a vascularized organ as similar to all endocrine glands. When be handled aggressively during surgery, this will dislodge tumor cells into the vascular spaces. So something when pathologists assess this tumor nest in the vascular spaces, it actually is iatrogenic from the surgeons rather than predict biological behavior of the tumor. However, when we use this rigid criteria, like a tumor invading through a vessel wall, so it's really the tumor invading the vessel wall, we can see it, or identifying a thrombus to the vessel wall, which is indicate that this is something happened before surgery, and this is indicated by the thrombus. We see the vascular invasion is very predictive of behavior of the tumor. In this series, distant metastasis was developed in 30% of full differentiated carcinoma and 50% of poorly differentiated carcinoma. So I think we have to make a rigid or a definite criteria for the vascular invasion. And I think now if, as a clinician, you should ask your pathologist when they write a vascular invasion to identify what's the criteria they are using as a vascular invasion. Now I'll talk about some of the margins. When we have, by definition, the margin is the outer surface of the thyroid gland capsule or the inked surface. There is only one problem when evaluating the thyroid capsule. Thyroid capsule is not well developed like other organs, like when you see in the liver or the kidney. It's only encased by pretracheal fascia. So that does make it sometimes a problem in evaluating, defining the margin of the capsule of the thyroid. So most of the pathologists and the clinician is agreed when we say about the margin, they talking about the inked margin of the thyroid rather than the capsule. Now we'll talk about the involvement of perithyroidal tissue, or what we describe as extrathyroidal extension. There is two definitions of extrathyroidal extension. The first one, the minimal extrathyroidal extension, which is indicate the presence of the primary carcinoma within the perithyroidal tissue, adipose tissue, or skeletal muscle, or sizable blood vessels. Here we're going to face one problem. Because adipose, as we said, the capsule is not well defined in the thyroid. So sometimes we see adipose tissue within thyroid parenchyma. Even some carcinomas, they contain adipose tissue. We know adipomatous metaplasia are found in papillary carcinoma. So for that reason, it's difficult if you see a tumor only involving the adipose tissue to confirm this is extrathyroidal extension. So a lot of authorities now, they consider minimal extrathyroidal extension if it's a tumor present in the skeletal muscle or sizable blood vessels.
4 minutes, please.
Okay, I'm finishing. Extrathyroidal extension is when extensive. There is, we said, the invasive tumor into subcutaneous fat adjacent to the adjacent viscera and recurrent laryngeal nerve. We know it's pathological. We know that extrathyroidal extension is very predictive of the oncological outcome. There is other item we need to include in the pathology reporting, not necessarily predicting the biologic behavior. So the take-home message from this presentation: hair cell tumor do not exist anymore in WHO classification of thyroid tumor. The genetic alteration of thyroid carcinogens are important for diagnosis, prognosis, and treatment of the patient. Diagnosis of papillary thyroid carcinoma by nuclear morphology, so that can be diagnosed by fine needle aspiration. Diagnosis follicular carcinoma by identifying vascular or capsular invasion, which cannot be diagnosed by fine needle aspiration, only we need histological examination. And synoptic report in 2014, I think, is a must for reporting thyroid carcinoma and all carcinoma. I think I stopped. Thank you very much.
Thank you very much for this comprehensive journey through